So it's an honor to introduce my friend François Varlet. He's from Saint-Étienne in France, and he has an extensive experience in minimal invasive surgery. He's one of the forerunners also for minimal invasive surgery in France, and he's going to talk about the laparoscopic treatment of duodenal atresia. François.
Thank you very much, David. Thank you very much, Professor Esposito, for your invitation. And I wanted to associate my new colleague, Aurélien Scalabre, and my old and very good friend, colleague, Manuel Lopez. As an introduction, I would want to speak to you about epidemiology and pathogenesis. About epidemiology, best reported in 2012 an European supervision of congenital small intestinal atresia from 20 countries registered, and with more than 5 million births. And from this study, they can note the incidence of duodenal atresia, about 1.3 for 10,000 births. Now, about pathogenesis, classically, we have two hypotheses from Tandler with the trouble of recanalization, and Love and Barnard about vascular accidents. But several theories are against this possible pathogenesis. First one, there is familial multiple intestinal atresia with autosomal inheritance, recessive or dominant. In other paper from Perry, multiple intestinal atresia describe no histologic vascular lesion, and with an experimental study, Fourcade and Perry demonstrated that it's possible to have multiple gastrointestinal atresia with adriamycin. Now we have more and more genetic hypotheses around the endodermic development, and from animal models, several mutations from growth factor or genes are able to create atresia. Fibroblast growth factor 2 can lead both duodenal and colonic atresia, hedgehog both duodenal atresia and anorectal malformation in mice, and CDX2 to increase intestinal atresia. As you know, Down syndrome is commonly associated with duodenal atresia. And finally, Gupta reported a study about 32 single nucleotide polymorphism, and to add increased risk of small intestinal atresia and duodenal atresia, and 3 add reduced risk. And finally, duodenal atresia begin forming very early in development, probably between day 33 and day 48 in humans. And probably the duodenal atresia occur sometimes by vascular accident or trouble of recanalization, but probably the most often it's a disruption of several genetics mechanisms around the endodermal development. Now, what about the treatment? As you know, you have to perform in duodenal atresia a duodenostomy by side-to-side anastomosis or diamond-shaped anastomosis. When you have a duodenal web, it's possible to treat with surgery, with the longitudinal incision, resection of the web, and transverse suture. The other procedures are uncommon, and it's possible to do duodenojejunostomy, but today uncommonly. And when you have a failure, And most often, it's possible to have to do duodenal tapering when you have dysmotility, but it's not performed systematically. What approach now? Classically, it's a transverse laparotomy, but today, what is the place of laparoscopy and the endoscopy? Why endoscopy? Because in between 15 and 20% of duodenal obstruction, we have duodenal stenosis, and several authors reported the treatment of duodenal web by endoscopy. And you can see in the slides, in the upper slides, balloon dilatation of duodenal web, and in the lower, an incision of the web with a knife. And I reviewed in the literature 26 patients treated by endoscopy for duodenal stenosis, between 7 days to 9 years old. The procedure to treat this duodenal stenosis are very different from balloon dilatations to knife, electrocoagulations, laser, etc. The number of procedures was only 1 in 20 patients, and between 2 and 4 procedures for four other. They had 2 failures, and laparoscopy or surgery was required because of bleeding of one annular pancreas. Now, what about laparoscopy? To treat this baby, we have to do a supine position, and we place 3 trocars, one 5 millimeter for a 5 millimeter 30-degree lance through the umbilicus, and beside 2 3 millimeters ports, and we use suspension to help the procedure. Now you can see kind of procedure, and in our procedure, the first step is to place transparent. Yeah, I'm sorry. I stopped just. Okay. And after a very good exposure between the wide first duodenum and the gallbladder and colon, we have to release small adhesions, as you can see. And we have to release the right angle of the colon to have a very good access to the lower part of the duodenum. Here it's possible to grasp this lower part and to release progressively. You can see the pancreas. We cut the small avascular adhesions, and now in the upper part it's possible to release more. Then we have to test, and you can see it's very easy to lift up the lower part of the duodenum. Now it's a future transverse incision for in the upper part of the duodenum, and it's possible to open with the monopolar hook or only scissors, as you want. Now it's the opening of the mucosa. and you have to enlarge this opening to have a very wide anastomosis. To help the procedure, it's possible to approximate the upper and lower part of the duodenum to have a very good stabilization of the two duodenal portions. You can see one knot, one stitch between the upper and lower part of the duodenum. And this allows to do a very good stabilization for the anastomosis. Now we have to open the lower part longitudinally to perform a diamond-shaped anastomosis. And the anti-mesenteric part of the duodenum to avoid the biliary tree. And now it's possible to begin the anastomosis. And with this first knot, if you want, it's possible to pull the thread through the abdominal wall for a good exposure. Our first running suture is now down. And we place the first knot inside the duodenum. I think it's not a problem. And now it's easy to do the anastomosis. And at the end of this first running suture, we have to stop it with another thread. Now it's the second running suture. And when we have a very good exposure, this suture is not so difficult. Tight the running suture before to stop and to end the procedure. We washed the peritoneal cavity and we leave a drain beside the anastomosis. When you have annular pancreas, it is exactly the same procedure. And it's possible to mobilize and to do exactly the same procedure. Then you have no annular pancreas. I think to help us, we have to use duodenal transparietal suspension, and this it avoids to place a fourth trocar. It's possible to do a suspension around the hepatic falciform ligament to lift up the liver also. To do a good exposure, it's possible to have to draw the duodenal anastomosis through the transparietal wall. With the first knot is possible, and we place the fixation, duodenal fixation. Now, in duodenal atresia, it's possible to have other malformation, other digestive malformation, and malrotation is common between 20 and 30%. And sometimes we have to treat this malrotation in the same way, but the procedure is longer. When you have esophageal atresia, we have to treat esophageal atresia first and duodenal a few days or weeks after. And about intestinal atresia, in the literature, it's about 5 to 6% intestinal atresia association. But recently, St. Peter reported a paper from more 400 duodenal atresia, and they found only 2 cases of intestinal jejunal-ileal atresia. And the conclusion is it's not mandatory to look for intestinal atresia in duodenal atresia under laparoscopy. It is debatable, but I think it's probably a good way. Now, what are the results? David van der Zee and Klaas Bax were the first to treat the duodenal atresia, and with the 22 patients, they stop 4 years later because they have 6 leaks, but they redo in 2008, and now the procedure are very good. This is very interesting to publish this result because it demonstrated that a learning curve is mandatory in the most often cases. And we have to be cautious before to treat this duodenal atresia under laparoscopy. Rothenberg and Parmentian-Bonnard published their results with no conversion and very good results, no leaks, and just one anastomotic strictures. And Mentesidu and Saxena reported in March 17 meta-analysis from retrospective and comparative data, and they compared the results to open and laparoscopic procedure with 123 open procedure versus 75 laparoscopic procedure. And they found no difference because the median weight and the smallest weight are exactly the same. About associated malformation, they had exactly the same incidence with Down syndrome, cardiac abnormality, malrotation. Just the operative time is longer with laparoscopic procedure with significant results. They found 22% of conversion. About complications like fistula, stenosis, or death, it was exactly the same. And the time to initial feeding or to full oral intake are the same as the length of hospitalization and duodenal dysmotility. And their conclusion was the laparoscopy as comparable safety and efficacy than open surgery. The prognosis of duodenal atresia remains the same, and the prognosis is dependent from cardiac malformation association with a high level of death. I think it was interesting to note the incidence of small bowel obstruction high for me, and I hope with the laparoscopic procedure this complication decreases. In conclusion, the place of duodenal atresia and minimal invasive surgery, I think laparoscopy get same results than open surgery. Probably it's longer in the first step. We need a learning curve, probably. If you have a very good train in laparoscopy, I think it's possible to begin. If no, probably you have to increase your train before to begin. I think it's very important to have a very good cooperation with anesthesiologists, because they have sometimes very small babies, and they need very good management of these babies. And we have today the same results, and I think with good training it's possible to do laparoscopic surgery. And maybe there is a place for endoscopy for duodenal stenosis. If you have a very good gastroenterologist, I think it's possible. Thank you very much.
Thank you very much, Francois, for this very nice overview. Have we had some questions already, the expert team?
Do you perform the anastomosis by separate stitches or by running suture?
I showed just a running suture, but I think it's possible to do
Okay.
interrupted suture. Yeah.
And one more question.
I think it's quicker to do a running suture, I think.
Olivia? Sorry?
So you displayed in your overview that we had an initial series that we stopped because of a high incidence of leakage, and that was in the time that we were doing the interrupted sutures. Because you're not very used to the distance between the two sutures you place, it needs to be a watertight suture. So after we changed towards doing a running suture, which is more equally divided over the anastomosis, we had no more leakages, and that's when we started redoing it again. So in our experience, the running suture was more watertight, more safe.
A comment also for me. I perform every time running suture, and I completely agree with you, because I think that is more safe, and so and no leakage. I think that could be the point of the initial failure in the experience, not only your but the pioneers.
Okay.
Those with open repair? Sorry. Is there an high rate of stenosis in patients underwent laparoscopic repair compared to those underwent open repair?
No, I think if you perform a very wide anastomosis, I think you can avoid stenosis. But Parmentier and Bonnard reported one case. I think it's possible. But if you perform a very wide anastomosis, I think it's a very good prevention.
If I can comment on that again. We had one case of a stenosis in a somewhat older child. It was a child with Down syndrome. And we think the reason for that was that we opened up the duodenum with cautery. And maybe this was leading to the cicatrization and recurrent stenosis afterwards. So initially you can do some cautery on the outer part, but if you complete your opening, you should do it with scissors and not with cautery.
Thank you. One more question. Abdul Samad, does laparoscopic repair decrease time to full oral intake?
No, I showed in the different papers the full oral intake is the same between, but just Spile proposes to begin alimentation, oral alimentation at day 5, even if you have a lot of stomach bilious retention, and with this they push the baby to hit, but probably they reported good results and a lower time to begin, and they have best results, but I don't know if it's possible in all cases.
A comment to our experience is not so large, but the only thing that we have noted is a faster recanalization because the gastric liquid is clearer, faster than in the other experience. So we start to feed faster, and we find that, I don't know, but we find that it was faster. I take a look to the literature, and I think 4 years ago, and the only data that emerged was that there was a faster advantage, there was a faster full feeding. But I ask you, and also, if is your experience or?
My experience is we don't have advantage with the laparoscopy to begin the oral intake.
What may be of influence is that usually these babies are taken care of by the neonatologist, and they are used to waiting for 5 days before starting feeding.
Yes.
So we had a very young resident in our neonatology department who didn't know and started feeding at day 2 and went well. And ever since we started feeding them at day 2, and they tolerate it very well.
I agree totally.
One more question,
According
Enrico
to
La Pergola. Did you observe any difference between open procedure and laparoscopy in the long-term follow-up? For example, did you observe symptomatic megaduodenum in some patients? And if yes, how do you treat it?
My experience is not so long because I began 5 years ago. I don't know if we have papers with a very long term. I never read this kind of paper.
Please.
I'm sorry to
Thank
comment
you,
every
David.
time.
Thank you.
I think principally in surgery, minimal surgery is always the best. And if you start doing more complicated surgery, you have more risk of complications. So in our experience, we have never resected or reduced any megaduodenum. And what you usually see is that they tolerate the feedings pretty well. They don't vomit anymore, they tolerate it. So I don't think you should do anything about the proximal duodenum. I always explain to the young residents is you may have had heavy rain and the whole ground is flooded, but soon the sun comes out again, but you still have the mud pools on the floor, and that's what you have in your proximal duodenum. It doesn't mean it doesn't go through.
Can I do? Also, I am completely agree. Our experience is not so great, but we think that we never reduce the duodenum, we have good results. I think that a great advantage of a minimal invasive is that you can reach easily the most pendant part of the duodenum to perform anastomosis without pulling, without stretching, and so the canalization, also we spoke about it, it's faster, and then this is another advantage without reducing the duodenum.
But I am not sure laparoscopy improve the results with the dysmotility. Probably, I think it's a forced duodenum, and laparoscopy open, I think it's probably no difference, but I'm not sure.
Maybe it's you touch it less. If you do open surgery, you pull everything out.
Yeah.
You touch it a lot. That will give maybe longer dysmotility than if you don't touch it.
We have to discuss again in 10 years to conclude.
François, I enjoy your presentation as usual. I would like to ask you, do you think that this kind of surgery is for all pediatric surgeons or for skilled laparoscopic surgeons? In other hands, in your group, you are the only one that perform this procedure?
Yeah, I agree. I think we need to be a trained surgeon to do this procedure, because remind it's a baby, it's a neonate, and we have to do quickly, and it's not safe to do this procedure during 3, 4, 5, 6 hours. I think it's not safe, and I think we have to be trained to perform this kind of surgery. And the other point is to have a good anesthesiologist, because sometimes they have to push curare to relax the patient and the abdominal wall. And I think it's very important, because when you have a good relaxation, we have a small pressure in the abdominal cavity, and it's it's safer.
François, thank you for this answer. Do you think that for this problem, newborn surgery and laparoscopy or thoracoscopy, you must use some cut-off time, or no? Because I see that there is the only specific difference in this number, but as usual. In your team, if you have a training surgeon, and at which time you change?
I have no cut-off time precisely, but I discuss with the anesthesiologist. If the anesthesiologist tell me it's not very good, the baby is not doing well, we stop. And I think the best decision is with the anesthesiologist, and we are not here to do performance. We have to treat a baby.
It's absolutely true. I mean, in the beginning, it took us longer time, but with gaining experience, it goes easy. I mean, you could see a much longer time in laparoscopic surgery in your presentation, but I think this is all learning curve from people. I mean, nowadays you can do it in 60 to 90 minutes, because your experience, you know what to do, you know where to go, you know where to put your stay suture and everything. So it's become a routine procedure. But I agree that in my idea, duodenal atresia is the most complicated procedure in neonates.
Yeah. And I think probably a good way for laparoscopics or young is to begin. Why not to begin? And after 1 hour, stop. And they have to do a conversion and to finish the procedure. And progressively, the procedure is quicker and quicker. And I think after a few cases, probably it's possible to perform all the procedure under laparoscopy. But we have to be safe.
Well, if I can comment on that, and especially to, of course, that director, I think it's a mistake to tell people that not everybody can do it. I think what the message should be, you need to be prepared to do it. Don't do it as the first operation you do, but don't say that you need to be extra skilled. Otherwise, I would not do anything. But there are courses. A very important tool is simulation, where you need to get those skills of suturing in reduced space before going into the patient. Now, just a philosophical comment. When did we discuss a learning curve with open surgery? Though it existed at the time too. And I think for this type of surgery, one very interesting aspect that I learned from class Bax and David van der Zee is to be two, because it is you get very tired very quickly when you do those knots, and if there is a second surgeon with you that can do 1 or 2 knots while you simply recover your focus, it's very important for those little cases.
If I can add just a comment, this is a very important point which is coming in this discussion. We have so many different kinds of surgery in very few number of patients. Complicated cases, not easy to solve, and the experience is not so good. Problem is how to give the possibility to do this surgery safe in a larger number of surgeons. Is never any surgery is not good if only one surgeon is doing that. If a technique is good, can be done in a larger number of surgeons. But the point is how to achieve experience. And this is the mentor, and progressively to go up. And this is very common in almost the most kind of these techniques that I've been listening today. And this is the point of our mentoring, our growing up, our younger colleagues. There is not one way.
All right, then
Thank you
if
very
there are
much.
no more questions on this topic, we'd like to thank you, François, for this very nice and for this very fruitful discussion.